our speakers from Eide Bailly, Rochelle Damon and Ralph Llewellyn. Rochelle has more than 13 years of experience, including more than 3 years at Blue Cross Blue Shield of Minnesota and more than 7 years working in multiple healthcare organizations across the country. Specializing in revenue cycle and technology implementations, she has assisted health systems throughout the country with charge master assessments, compliance reviews, charge capture improvements, as well as electronic health record implementation, conversions, and optimizations. Rochelle brings strong analytical skills and a thorough understanding of the revenue cycle that allow her to quickly identify issues and create solutions to improve revenue cycle performance. Rochelle holds the EPIC Resolute Professional Certification designation. Ralph has over 20 years experience in the healthcare industry in the area of finance, leadership, reimbursement, and operations. He began his healthcare career as a hospital CFO for a 49-bed hospital with a 116-bed nursing home. For the last 19 years, Ralph has been with Eide Bailly, where he is currently the director for critical access hospitals. He assists providers with the development of solutions in the area of cost report reimbursement, charge master development, billing compliance, operations, leadership, organizational structure, process flow, board education, licensure status, and EHR incentives. Now I'll turn it over to Ralph and Rochelle.
Well, thank you very much. We appreciate this opportunity to get to visit with you today on the impact of high deductibles on the revenue cycle management and the best practices around. So with that, we'll get started. I'm going to start out this conference in walking through the front section. Rochelle will then step in and take some of the middle, and I'll do a little bit of the wrap-up on the end. So let's first of all start by talking about, what has happened in the industry that brings us to this point, because there's been some significant changes when we look at the revenue cycle in organizations in the last 5-6 years. The Affordable Care Act brings with it a lot of the impacts with this new delivery because of things that have happened. As we saw this be implemented, we saw a definite increase in the amount of insurance costs. This is the premium costs. As you have more people being covered, more items being covered, there was an increase in the cost of the insurance premium. With this, it definitely brings pressure on the employers because they are covering a larger dollar amount. Now, not that they haven't necessarily passed some of that on to their employees as individuals, but there's definitely a higher cost that they're seeing coming through on that premium of which they're absorbing a portion. And then there is the pressure on the individual, the employee, who is seeing either higher premiums because they're paying for it all themselves, or they're an employee and they're seeing the amount of premium that they're having to cover as their portion increase. On top of that, the biggest piece that we see internally as an organization, as a healthcare organization, is what it does to the patient's responsibility. And that's really the impact on the revenue cycle. Copays, deductibles, co-insurance, all of them increasing significantly. And I'll show you a couple slides in a few minutes that just shows what's happened in the last several years in the area of copays, deductibles, and co-insurance. The days of $25 and $250 deductibles are gone. So with this becomes a much larger portion of the base that we have to come to collect from individuals that we're not sure if they're going to have that ability to pay. So this is that increase in credit risk. And what we've seen because of that is escalating bad debts. And that's regardless of where we go throughout the country. Obviously, some parts of the country have a better economy than others, but even with the better economy in certain portions of the country, we're still seeing escalating bad debts. And a lot of this is due to the less favorable payer mix, which has higher deductibles, higher copays, as well as with the advent of the marketplace, we're seeing insurers that are tougher to deal with, and different insurers. And a big chunk of then what we're seeing is more and more of the collections that we're doing every day are really self-pay. They may be insured, but really what we're chasing down is self-pay balances. It's estimated the individual's annual deductible has increased 146% in a 10-year period from 2003 to 2013. And surveys are showing that 1 in 3 Americans are struggling to pay medical bills. And of that, 70% of those are insured. So it's not just individuals that don't have insurance that are struggling to pay their bills. It's those that have insurance but have extremely high deductibles, co-pays, etc., that are struggling to figure out how are they going to pay their bills. Now, in this slide shows the average annual premiums for single and family coverage over a 15-year period, 16-year period, from 1999 to 2015. And in 1999, an average single premium was $2,196. In 2015, that had escalated to $6,251. In the same time period, a family policy premium went from $5,791 to $17,545. So it's increased threefold during that time period. During the same time period, when we look at, or a shorter time period, 2006 to 2015, we can see what's happened to deductibles. Deductibles, when we look at 2006, the majority of the deductibles were under $500. Now we're finding that over a third of them are over $1,000, and it's not, and this is for a single plan, it's not unusual to be hearing of $2,000 and $3,000 deductibles today, and ever growing as we move forward. We also look at the area of copayments for physician offices. If we go back in 2006, over 50% of the copays were under $20. And now when we look at 2015, over 25% of those are over $30, and that amount is growing every day as we move forward. We're even hearing $40, $50 deductibles for office visits as we work with various providers in the market. As we look at the Affordable Care Act, we had employer mandates, we had the healthcare exchanges, we have this Medicaid expansion. The positive thing of all those is that there is definitely more individuals that have insurance today than what had insurance in the past, which on the surface sounds like a very positive thing. So we have a lot of patients now that have insurance for the first time in their life. Unfortunately, just because they have insurance doesn't necessarily mean they understand the insurance. What we find is a lot of times individuals will have a claim. It'll get submitted to the insurance company payment. That claim comes back with some co-insurance, deductibles, etc., gets sent off to the patient, and this new patient with coverage is responding back, well, no, you have to send it to my insurance company. I have insurance now. And it's that lack of understanding that there are still deductibles, there's still co-pays. They confuse coverage with there being first dollar payment. So they're accessing the health systems now, which makes a lot of great sense, but it's not with the understanding that they're going to have some obligation for a portion of the bill. So as we get talking into the whole issue of the impact of high deductibles on the whole revenue cycle, we'll obviously talk a lot about collections. But anytime we're going to talk about collections, we really want to start with the importance of implementing a strong charity care plan. And there's several reasons to do this. As we look at the whole revenue cycle process that we're going to talk about today, the focus is not talking about the denial of care. What we're trying to figure out is who has the ability to pay, where should one be focusing their efforts to make sure that you can collect all of the potential cash that is out there to continue to fund the operations of your organization. So when we look at a strong charity care plan, it's really helping you delineate who is able to pay so you can collect from those who are able to pay. And then you can determine, hopefully, at the earliest potential time possible, who qualifies for charity because they cannot pay. And obviously, to demonstrate that they cannot pay, they have to be willing to demonstrate that they have an inability to pay, completing some paperwork, maybe an willingness to apply for Medicaid to make sure that there isn't another payer that would be willing to step up and pay that bill. Because the focus on charity care is determining who really does not have the financial means. What we're trying to focus on here is who is going to most likely become a bad debt anyway if we were to attempt to continue collections. Let's get away from that. So the benefit of the strong, consistent, and fair charity program is that you are going to identify early in the process, not later in the process, hopefully earlier in the process, who qualifies for charity. And what that's going to help you do is focus, again, all your efforts on individuals that have the ability. The charity care program, if you're a nonprofit entity, also helps fulfill the nonprofit mission of your organization. Some things for people to consider in this area are a sliding fee schedule program. You know, the discount program at your organization that takes into account an ability to pay based on the amount of income they have that may be variable. Some people might get 100% discount, some might get 50, some might get 20, depending on where they're at within a scale of income. And what these help address is inequitable access to health care for all individuals based on their ability to pay the bills. When we look at charity care and discount sliding fees, typically the discount amount is going to be based off of federal poverty guidelines. Typically what individuals are saying is if you meet the poverty guidelines, maybe we'll write off 100%. If you're not 150%, maybe we write off 50%, etc. It's using those federal poverty guidelines as the base. Occasionally we'll see organizations try to create their own internal guidelines, but they're basically trying to recreate something that's already available in the form of federal poverty guidelines. So looking at the guidelines, really hopefully with the sliding fee, it's designed so hopefully you can at least get some of the costs back, that it covers what it takes to operate as an organization. Best case scenario when we look at charity care and discount programs is that they are well designed for a couple of things. One, ease of use. Ease of use for your staff in the ability of being able to hand out appropriate forms, communicate it to individuals, communicate it early in the process so that we can keep that process going. Availability of data. What we're looking for there is trying to have a format in such that the data that you need to make the determinations is not something that is difficult for the individual to capture or to recreate, yet making sure that there's adequate data to truly prove that they do have the financial need for the charity care discount program. And in a perfect world, it would be real time, something that we can really collect quickly, process quickly, and move forward. Again, the full process on charity care is figuring out as quickly as possible, as early in the process, those that are not going to have the ability to pay, so we can focus all of our expensive resources and collections on those that we actually have the potential of collecting from over time. Again, early detection of the account balances. If you are a nonprofit organization and you need to meet the regulations in 501R, having a discount or sliding fee schedule program allows you to help identify that. This will reduce bad debt if properly put together. Now it just reclasses into another write-off column, charity care, but again, that really does help support your nonprofit status, as well as reduces the amount of time that individuals are trying to chase down accounts that will never be collectible. When we're working with organizations, at times it's very frustrating to find out how much time they spend trying to collect accounts that are eventually later in the process identified to be charity care. It would have been really good if they could have found out that time earlier and then been able to spend their time on other accounts that had a potential for collectability. With that, I am going to turn over the Upfront Revenue Cycle Best Practice for Collections portion to Rochelle.
Hi, thank you, Ralph. So yeah, now I'm going to go through some of the best practices that we see working well in top performing organizations in order to get these collections done up front. Like Ralph was touching on, it's extremely important that we get those dollars sooner than later. It's more likely that we're going to get payment if we get it up front unless we wait for after the service, the patient gets their bill. It's going to be a lot less likely that they pay that bill after the fact, after they already had that service, than if we can get it up front ahead of time, hopefully before they even come into our organization and have that service. So one of the things that we recommend is making sure that we're delivering a consistent message to all patients about upfront collections that are coming into our organization. And a lot of these small rural communities, you know, we're all neighbors, everybody talks. You know, if one person finds out, well, they asked me for $500 before my service, and, well, they didn't ask me for anything. Well, how come we're not delivering that same message to all patients coming into our organization? And then, again, in the community, it just puts out that expectation that, hey, when you come here, we are going to ask you for that, and the community just gets used to it, and they expect it when they walk in the door, or, again, before they even have their service at your facility. So again, we need to consider having this discussion with the patients at all areas within the organization. Patients come into a facility all hours of the day and night, including, nights, weekends, pretty much 24/7. So we want to make sure that we're able to have these conversations with the patients at all times, not just Monday through Friday, 8 to 5, when they come to our registration desk or they come to the business office. We want to make sure that we can do this 24/7. So making sure that, our lab staff has the ability to do upfront collections and have the conversations, radiology, ER, which we'll get into a little bit later, and our nursing staff, and making sure that we do this for every and all visit that happens within our organization. So it's very important that we start the upfront collection efforts prior to the patient even presenting to their visit. Like I said, it's a lot easier to collect before a service than after they receive the service. So it's a really good idea to pull a report of all patients that are coming in for scheduled care. Again, this really only works for those things that are scheduled. So run a report of all patients that are scheduled either a few days prior to their appointment or maybe a day before the appointment. Really going through that list of patients, using that report to perform insurance verifications, eligibility screening, as well as obtaining any prior authorizations that may be necessary for that service that they're going to be getting at your organization. This is a really good opportunity to verify if the patient has any copays, coinsurance, or any remaining deductible that can be identified, and we can start having those conversations with the patients. This is also a great opportunity if we have any insurance information that's wrong, we're unable to verify that patient's eligibility, we can actually call them prior to the visit and obtain that additional information and have that information then obtained and verified, ran through the system so we know when that patient presents that that's not then going to lead to a denial down the road because we have invalid insurance information, and again, making it a little bit more difficult for us to collect on these patients. So the list, one of the other things the list can be used for is for patient reminders. So when the call is made to the patient, this is a great opportunity to remind the patient of their obligation to pay, as well as requesting payment at that time or setting up a payment plan. So again, having that early reminder, that expectation on the patient that when you come here, we do expect you to pay for your service up front. And the more they hear the message and the more they hear it delivered consistently, again, it's just going to spread in the community that that's what's expected when they come to your organization. So one of the things, in order for this to be successful, is that we really need to be able to provide patient estimates. We have to ensure that the organization has the right people, processes, and tools in place in order to provide these patient estimates. There are a variety of tools available in the market with a widely varying amount of accuracy within them. And one of the things that causes some inaccuracies, especially in the deductibles, is the information is only as good as what's on the payer's database for processed claims. So it could be a timing issue there. The patient may think they have more of a deductible left than they really do, or vice versa. So we really need to stress to the patient that these amounts are truly only estimates, and the actual amount owed may be more or less when the claim actually becomes processed for payment. So again, reminding them, this is just an estimate. It's the best knowledge that we have at the time. And then, if they do pay more, you can always refund them the money, but it's better to refund than having to keep asking for more. One of the second things to consider is having a charge master that's really the right size to your organization. If pricing, patients are really shopping around with these high deductible health plans, especially for like cataracts, colonoscopies, more elective procedures. So if your charge master set up more on time, where, one provider takes 20 minutes for the service, another provider takes an hour. There's a wide variance in what the charge is going to be for that procedure. A patient's more likely to go to a place where they know exactly how much it's going to be, even if it potentially may be more than the organization across the street. They're going to go where they know what they're going to be paying. So it's really important to consider having a charge master that's concise for these types of services, that we can really bill on a per procedure basis. So we know when I'm coming in for a colonoscopy, I'm paying $2,500. When I'm coming in for a cataract procedure, I may be paying $3,000, $4,000. And that includes all my supplies and whatnot, unless, of course, there's something above and beyond the norm. But, they know exactly what to expect when they come into your door and what the bill is going to look like when it gets sent to them. So consider, again, moving towards more of a package price for those types of services that are very succinct. There's not a lot of variability in the process, not a lot of variability in the supplies, the time, and whatnot, and coming up with an average price that would suit each case. And that way the patient knows, again, exactly what they're going to be paying for that service ahead of time.
Rochelle, I think that was a really solid point that everybody really needs to look at. We still find a lot of providers that are really trying to make sure they have a sticker or a charge on every little item they possibly can, thinking that it drives additional revenue. And as you and I know, working with providers, that really all it does is cause additional work, additional opportunities for error, and now it's even creating that additional struggle to provide a good estimate. Our best practice facilities are definitely those that have really streamlined that charge master to make it very efficient, and at the same time they've also been able to maintain or improve their overall profitability.
Yep, it definitely reduces the cost of chasing down that, $5 item or $10 item. It costs us more money to try and find it and put it on the bill than we would actually ever get paid for it. So, yeah, definitely helps with charge master maintenance, charge capture, all of the above, and of course the patient estimates. Thank you, Ralph. So another thing that's very vital to the success of upfront collections is scripting. As I touched on earlier, scripting assists with delivering a clear and consistent message across the organization. At each department, every time you present to every department, you hear exactly the same message. So the patient, there's really no variability in it. They truly understand what's being asked of them. It also helps staff develop more confidence when having really difficult financial conversations with patients. And you can also develop scripting on how to deal with maybe that more difficult patient, the angry patient, that patient that doesn't want to pay, maybe a little bit more difficult with you, having scripting to kind of drive those conversations in the right direction as well and diffuse that patient before it becomes, out of hand. Scripting about collecting copays, coinsurance, and deductibles should also be added to every appointment reminder call. And also, it's really good to have language about that on statements as well. Again, we're hoping that it doesn't get to the point where we're having to collect after the fact, but having that reminder in any way possible and getting that visible to patients, again, it just puts out there that expectation of them. They know they're going to be paying when they come. Excuse me. So in the area of in the new era of healthcare, more and more payments, for healthcare related to the patient versus coming from the insurance. So this shift in payment can result in significant cash flow implications for some facilities. Self-pay patients tend to take much longer to pay their balances than insurance companies do. Most insurance companies pay within 30, 60, 90 days, much quicker than a patient could pay their $5,000, $10,000, dollar deductible balance that's out there. So this could lead to, little commercial cash in the first quarter of the year when deductibles basically reset for the new calendar year. Plus, it's right after the holidays when many families are already cash-strapped at that time. So it's much more difficult to collect that money in that beginning of that first quarter of the year. So, with all of this, payers are also increasingly wanting to pay us less on top of this. So not only do we have more self-pay patients that have difficulty paying that deductible, high deductible, but payers are really ratcheting down on what they want to pay us as well. So, where are we going to get our cash flow from? How are we going to find this money? So all of these are reasons why we really want to push that upfront collection process and why it's so vital to the organization to get every dollar in that they possibly can. So one of the things that you need to look at is your payment policy or payment plan policy in the organization. Hospitals can't afford to be the bank. We really need to restrict the time frames that patients are allowed to pay that balance in full. So, we don't really want them to have 1 year, 2 years, 3 years, because every year that $5,000 deductible is going to compound. So year 1 we have that $5,000, year 2 we have $10,000, year 3 all the way up to $15,000 that we're expecting from that patient. So if we can get payment plans set in place, expectations where we want your balance paid within the next 6 months or at least within the full, calendar year, so it's paid in full before it resets again next year. And we really can't be afraid to have this payment issue addressed with the patient. What's the value to the patient, or what's the value of a patient that doesn't pay their balances? What's the cost of that patient that doesn't pay their balances? So again, the more we can collect from them, the better. So the next place we're going to hit on is the emergency department. In the era of the high deductible health plans, we see care kind of shifting to the emergency room. The U.S. Centers for Disease Control and Prevention estimates that 8% of the emergency room visits could be handled in primary care. 8% doesn't seem like a lot, but it's 8% of patients that don't need to be in the ER, that are clogging up the ERs and receiving a higher cost care than it would cost in their primary care setting. Oftentimes the belief is that payment is not going to be addressed during the emergency room visit. And this has been true for many years. I know personally when I've been to the ER, I have never once been asked for payments, copays, deductibles, or anything. So that's just something that patients expect. Oh, they're not going to ask me for payment while I'm here. And providers have a fear of violating EMTALA. They've been told through the years that payment cannot be inquired about in the emergency room. The patients have to be triaged, cared for, so we can't have that financial conversation with them, and we can't deny care for them in the emergency room on basis to pay. So emergency departments are assuming more and more patient responsibility, as well as experiencing higher volumes, which are leading to increased patient wait times. Some ERs have hours and hours of wait times. They're clogged up. Everybody's in there from the common cold, to shotgun wounds. So, and of course, those patients with the common cold are going to wait much longer than those patients that need emergent care. So we have decreased patient satisfaction. They're sitting there waiting for hours and hours to see a provider. Crowded emergency room conditions, overflow happening. So what are we going to do about all of this? So one thing that in the emergency room, in order to meet and not violate the EMTALA rules and regulations, a patient must be triaged to determine if they are needing emergent or non-emergent care. So basically, that's what you need to meet EMTALA. We need to determine, okay, is this patient coming in? Are they emergent? Do we have to treat them? Get them stabilized, get all their emergent conditions addressed. Once we do that, when a patient's considered emergent, once we take care of that emergent need, again, all those conditions have been addressed, stabilized. At that point, then you may engage in a financial conversation with the patient. At that point, all the EMTALA regulations have been met, and now we can start having that conversation. How are we going to pay for this stay? What do you owe for this stay? As stated earlier, these efforts should take place at all hours of the day or night by all staff with zero expectations. Emergency rooms are a 24-hour business, so we want to make sure that we have the ability to have the conversation with the patient 24 hours, the ability to do insurance eligibility verification, and reaching out to that third-party tool to see what they have for any deductible, co-insurance, co-pays, and start that conversation once they've been stabilized. For non-emergent patients, we're able to have that conversation about payment obligation much earlier in the process. So immediately after the patient's triaged and prior to providing any treatment whatsoever to the patient, we can start having that conversation with the patient. If we determine that the patient isn't emergent, we could consider directing them to a non-emergent area or other care settings, such as their primary care provider, a walk-in clinic, something of that nature, so we can move them out of the emergency room and start taking care of those more emergent patients that really need to be seen in our emergency setting. I know it's a little bit more difficult if you don't have any other options, after 5 in the afternoon in your area. We may have to continue taking care of those emergency room patients in the emergency room. But if it's a weekday and their primary care provider has an opening or a walk-in clinic has an opening, maybe shift that patient over to that area. The one thing is patients may not really be happy with that for the fact that they're already in the emergency room. I don't want to go elsewhere. Why can't you just see me there? So that's something that would need to be addressed in that case. And then providers may also kind of push back a little bit because we've already done the work, we've triaged the patient, they're already here, and we're not going to get any payment for that. So there needs to be some education around that, and those issues need to be addressed before we start looking at shifting that patient to the primary care setting or less costly setting. But it's definitely the way we should do it if it's possible. So another consideration to facilitate collections in the emergency department is creating a checkout location, a checkout desk that's accessible for administrative staff, nursing staff, and whatnot. It should have a PC and other necessary equipment to verify insurance, collect payments, whether it's an online payment system, being able to swipe a credit card, take a check, cash, all of that. We want to be able to take that payment, because if we can't take that payment, how's that patient going to pay us? And in the emergency room, again, it's a 24/7 business. The business office of most hospitals is, Monday through Friday, 8 to 5 type of department. So we want to make sure that we have the ability to do all of that within the emergency department itself. And we also want to think about utilizing a third-party tool for estimating deductibles, again, making sure that we can start collecting on those too while the patient's in our emergency room. One other thing to consider with it too is emergency room is a very hustle-bustle type of area. Patients could easily slip out the door without stopping at that checkout desk and having that final visit checkout, where we do all the collections if need be. So one of the facilities I worked at had a really great idea where we got these mobile carts that we put a laptop on them. And again, once we've met all the EMTALA requirements, we're able to wheel that mobile cart right up to that patient and start having that financial conversation at the bedside with them. So that alleviates the expectation of them or, hoping that they stop at this checkout desk instead of them coming to us. We can go to them and have that conversation. So in summary of the collection efforts, Ralph touched upon this. Charity care is an integral component of this whole process. Making sure that you have a really strong charity care process in place so we can identify those patients that we truly can collect from up front, and we don't utilize all this extra time for those patients that we're never going to collect from. Making sure we have a strong upfront collection process, again, delivering a clear and consistent message to all patients that come to our organization. We don't do it for one and then we do it for the other, and it just, really making sure that it's clear and consistent. I cannot stress that enough. I've said it multiple times throughout the presentation. It's definitely something that sticks. I know for me, being a patient and going to my provider, I know in the organization I go to, I'm going to hear that on my appointment reminder. I'm going to hear it when I present to my visit. I'm going to, see it on my patient statement. It reminds me that, hey, I need to pay this balance. And again, emergency room services are not exempt. For many years, providers have been worried about violating the EMTALA rules and regulations, and as long as the patient's triaged and stabilized, we're able to have that conversation with the patient in the emergency room. It's no longer an option; it's a necessity in this day. So I'm going to turn it over to Ralph to review the National Rural Health Center tools.
Okay, thank you very much. I think that last comment you made, Rochelle, about it's no longer an option to have these types of collection efforts is so very key. When we had low copays and payers didn't have as stringent of schedules and everything else, if we missed some of these things along the way, there's a little bit of forgiveness in the profitability that we were making on other patients. And today, unfortunately, as fee schedules get tighter, and the deductible amounts and the balances get to be greater, it becomes more and more difficult to fund the necessary resources of our organization. So it is not an option. Fortunately, there are a lot of tools out there, and that's kind of what we want to walk through here at the back end of this presentation is some of the various tools that are out there that have already been placed out there for you to use as guides and resource information. So the National Rural Health Resource Center has several tools. They have a revenue cycle management best practice guide, a Road to Value webinar series, and a rural hospital toolkit for transitioning to value-based systems. And I want to walk you through a little bit of some of the information that's out there, because as you look at doing any of the pieces we talked about with the charity care, when you start looking at the upfront collections, ER, all of those components, the things that you need to know in greater detail are going to be available in the tools that are out there on the National Rural Health Resource Center website. The Revenue Cycle Management Best Practice Guide, this was developed for rural providers using best practices in the revenue cycle management. It was also put together to help flex coordinators. We work an awful lot with flex program coordinators and state offices of rural health directors to help them identify what they should be putting together for educational trainings. And this section has a couple of items. It has a guide, and then it has 4 recorded webinars that walk you through the guide and provide you with additional information as to how to implement some of these pieces. This addresses scheduling and pre-registration. We talked about that a little bit today, about how you have to have the scheduling in the pre-registration and follow up with the patients, notifying them of some of your copays. Walks you through a patient and registration admissions, the emergency room admissions, charge capture and coding. In a day when we have higher deductibles and copays, it is very important to make sure that we're capturing all the charges that we have earned. And unfortunately, we find significant errors or omissions in charges with most facilities. This is not something that's just a process that we see a challenge in small facilities. Even the large facilities, the metropolitan facilities, leave a lot of charges on the table because they didn't capture them. Talks about timely filing, billings and collections, using your collection agencies and what you're going to be doing in that process. Denial management. A lot of people never get paid for what they did because they didn't have the right processes in place on the front end to avoid denials. It also has some really good revenue cycle metrics. Talks about those key indicators. This one here includes a couple of checklists. One is a practice guide or practice checklist, a great tool to be used in that arena. And then there's also recommended key performance indicators, a great way to identify how well is your organization, your department operating in the area of the revenue cycle. We also have these webinars, Keeping Your Patient at the Heart of Your Revenue Cycle. That one there talks about creating a positive patient experience. Obviously, we know with patients coming back, we want to have high patient satisfaction. As we look at a lot of the reform issues that are out there, a lot of things on value-based purchasing have to do with patient satisfaction scores. So looking at patient satisfaction in the revenue cycle, looking at how we communicate with our patients to keep them happy and hopefully continuing to come back. Financial clearance and pre-registration. This is, how to prepare for your processes for success in the revenue cycle. Account management, moving from denial management to denial avoidance with process improvement. We find a lot of organizations that are able to overturn denials and are quite proud of the programs they've put in place to be able to reverse denials. What this is going to talk about is what do you put in place to avoid that denial on the back end, so you never have to worry about expending those resources and that time, that effort that it takes to reverse the denial in the first place. And then becoming a patient-focused but metrics-driven revenue cycle team. That's really going to talk about measuring the performance of your revenue cycle. Some metrics out there to help identify, are you performing well, average, or do you have some work to do on your team? Then the Road to Value webinar series. This has a guide and 3 webinars. The Road to Value talks about that transition to new payment models. So the first webinar is on the Road to Value. What's the financial strategy to survive the transition to the new payment model? This one talks about the need for transition. Talks about the top 10 indicators for providers to monitor. It talks about the importance of strong indicators, especially as we start to move into new payment models and documenting value. The second and third webinars, what's the most important to know and do to financially position the hospital for the future. They're parts 1 and 2. They talk about monitoring and improving financial viability, monitoring and improving the quality, improving data management skills. There's so much more data out there that needs to be managed in the revenue cycle. Good information on that. And then talks about how to access ongoing education, and at the end of the day, enhancing value as you're